give you your 2-minute warning
Yeah.
by standing. Hello? Hopefully the mic's working. Welcome you to the Nursing Informatics 4 conference. We have a series of 5 the app hasn't been working, so I'll be unable to let you know where the presenters are from. So apologies for that, but I will do my best with name and title of the presentation. So I'd first like to introduce Professor Saarento, and she's from the University of Eastern Finland. Her presentation is on mentoring professionals to use digital tools in home care.
Good afternoon. It's really a pleasure to be here, and I bring you warm greetings from Finland. And please have my title, and I would like to acknowledge my co-authors, Eija Kivekäs, Ulla-Mari Kinnunen, and Johanna Ikonen, who come from the same university. So, just to understand some things about Finnish healthcare system, there is a slide and some information about how we operate. The Finnish healthcare system is based on public healthcare services to which everyone residing in the country is entitled. According to the constitution of the Finland, the public authorities shall guarantee everyone adequate social, health and medical services. So our system is mostly public. But in addition, numerous private healthcare services operate also in the country. So nowadays, when there is huge problems in terms of public services, more people tend to go also to private sector to get quicker care, which is perhaps the system also in other European countries. So what did we know about the use of digital tools in home care before we started our study and project? The use rate of electronic health records and client information systems in healthcare facilitates 100%. Information systems are essential for managing health and social care data, especially in long-term care and elderly care services. And more and more digitalization and assistive technologies have been introduced to meet future challenges for aging populations, and assistive technology is currently used in various forms to support older patients and especially nurses and other professionals' work. Patient and client information system did not speed up documentation based on our studies, and there was no integration between different information systems. But however, nurses' positive attitudes and moderate skills regarding patient and client information systems did not eliminate the associated challenges. And again, I think some common things are that the age variation among nurses working in healthcare is prominent, reflecting variance in also digital skills. So that was the situation how we decided our project. Our aim was to test a mentoring program for professionals working with digital tools in elderly care services. we had a project called Development of Digital Capacities and Approaches in Old Age Care, so that was the funding name, and we had the acronym VADICI. And a reverse mentoring model was adopted with the specific goal of increasing healthcare professionals' digital skills in elderly care services. And there was the particular focus on identifying how reverse mentoring influences nurses' competencies with patient and client information systems and assistive technologies in elderly care services. So the organizational approval of elderly care services departments was required for 2 surveys. The data collection from healthcare professionals is very strictly regulated in Finland, so there has to be approval by the provider. And the starting point was a survey utilizing the measurement tools used in a nationwide project earlier organized by the Finnish Institute for Health and Welfare and the previous WellTech project, which also focused on the digitalization and adoption of digitalization earlier. So in autumn 2022 and 2023, an electronic survey was sent to the departments providing elderly home care. Based on the first survey's results, mentoring focused on 7 units providing elderly home care. And advanced nursing students, after a certain mentoring program, acted as mentors, totally 14 of them. And mentoring meetings were organized in those 7 units for 1 week, totally 35 meetings. And the mentees were mostly licensed practical nurses and registered nurses. The discussions focused on current working methods and information security, which is also a big topic in all over healthcare services. The service included background and multiple choice questions. A 5-point Likert scale was used to examine variation associated with the use of patient and client information systems. Here you can see the model we used for the mentoring. And of course there needs to be secure and leadership support for the whole process. And so when we first made a survey, we identified the mentors and also decided the mentees from the nursing college. And then the students who volunteered to be part of this project, they got the special scores on this support they should give and about the discussion methods. And then they had meetings and provided support to the participants, to the mentees, and then we monitored by the survey afterwards. And I don't know if we celebrated success, but anyway, the most satisfied group was the students who really had something new to experience also. So the results are not very successful, but anyway, we got some results. And there is a slight change in information system through mentoring because the use of in terms if you are a beginner or if you are an experienced nurse, I think they got some improvements. And then change in use of assistive technology through mentoring also changed when we think about this if you are a beginner or if you are an experienced user. And what was important was mostly this one, because you know that I spoke about 100% use of electronic systems. A lot of paper is still used, and different kind of papers are passing through the wards. So and also when you go home visits and they come back with some kind of paper documents. So that was very important that there is something improvement that the daily use of papers diminished at least somewhat. And then the other thing was that the daily use of these assistive technologies also improved slightly. I think that the daily use of safety devices, different kind of alert systems, how that they can guarantee patient safety or client safety at homes, I think that was very important. And then, of course, we hope that this medicine dispensing robot, which is in use in the units, was more actively used, but it didn't affect at that. But I hope in the future, because that was discussed with the nurse students. So I think that the mentoring test advanced nurse students to taught new skills to professionals in elderly home care. They were very, very nervous about how to behave and is it really their task to do it. But I think that they were, as a group, really ready to take that responsibility. And licensed practical nurses' experience as users was high, and I think that reflects the comprehensive implementation of the electronic information systems which have been long in place. And also, as I mentioned with those tables, the findings revealed that mentoring slightly enhanced home care professionals' daily digital skills, which is also important to use them daily. And a positive indicator was professional motivation to use these tools and seek solutions to increase their use. So to discuss also together between the professionals, not only with the nurse students and the professionals. And they used different digital tools and were more confident users with assistive technologies. So I may conclude that the cooperation between mentors and mentees was highly successful, creating a more positive atmosphere, and reverse mentoring proved to be a successful method to strengthen the use of the existing digital tools in elderly care services. And our findings revealed that the professionals working in home care were motivated to use digital tools, and that was also something they hesitated in the beginning, that would they participate this kind of project. So this is acquired, so now it's suitable time to support training and encourage the acquisition of digital skills and use existing tools. So that was a comment from a head nurse. So we were really happy that we got also support from the organization. So thank you. I can hear you.
Thank you for your great presentation, Karin. You're doing wonderful research, and this is one of the very important areas through that project. And I might have missed it because I came a few minutes late in, but did you consider like the implementation theories and implementation elements as part of this project?
We had in our plan, but I just presented here how we tested the mentoring method. So this is a bigger project, but I just got it, just this part of the project. You are absolutely right that we had that behind our scene.
And you said that, thank God, the management supported us, so that was not a requirement in the beginning, but it became part of it in the project.
It comes when you apply to do the research, so the management looks your application, and in that way they know what is happening there, so they were eager to have some feedback also afterwards. Yeah.
Thank you very much.
Yeah, you're great. So I have the pleasure of introducing Dr. Nick Hardaker. Dr. Nicholas Hardaker. He is from here in the UK, and he is presenting reinterpreting the nurse record for an electronic context development principles. Go away, take it away.
Thank you. Correct. So I get a little bit nervous before presentations, as many of us do, and so I kind of self-sabotage to some extent. So today's was I submitted my slides yesterday, and then this morning started thinking, I'd like to present something different, which is never good. Second thing I did was I have lost my mobile phone. That's a good one. That's like some kind of Munchausen's that I'm proper self-sabotage because my mind is completely distracted. So forgive me, I may jump over some slides because there's a couple of things I do want to say that perhaps aren't in the slides themselves. But the study I'm going to talk about I believe, is very important work. I'm not trying to big up the study. I believe it's essential work. This morning, I went to one session, and in a single session, I heard information systems revealing really towards the lower end of benefits. We implement information systems in nursing to reveal benefits, and yet the study was showing it's at the lower end of those benefits, which is very disappointing. The next presentation said we need to improve software to work with nursing workflows. Again, a disconnect with nursing workflows. Again, disappointing. The next one was about moderate levels of techno-stress related to the implementation or configuration of technology. Disappointing. You know, so I'm just wondering how many people either have used health information systems in a nursing context recently. So there's not many. So how many people? There are some. Whoa. If you don't mind raising your hand, if you believe you've had nothing but a positive benefit from those electronic health record systems. So nothing but positive. Okay, there's a couple there, which is really reassuring. That's not the story I hear. And in fact, the presentations that I've heard and I've witnessed don't say that to me. And I'm going to talk about a study where it definitely is not the case. So what we did is intentionally exploratory. Do not question the methodology. It's loose, but it's intentionally exploratory. And what we wanted to do, we thought something needs doing with electronic health records because it's got a history of kind of problems and complaints and issues, and doesn't seem to have moved on too much. I'm happy to be corrected on that by individuals, but in general, they get a poor press. So what we decided to do was actually to explore that. Sorry, I should just acknowledge my co-authors, Dawn Dowding, Patty Dykes, and Walter Sermius. Many of you will know these people, if not in person, then by name. So in overview of what I'm going to talk about, I believe that the full potential of EHRs is yet to be realised. So that's quite a polite way of expressing what I said before. There's a need to reconceptualise the nursing record. I truly believe that. And what we tried to do was to think about potential new approaches to documentation. So the findings from this study were then developed into a set of design or development principles, which they appear in the publication which is in the proceedings, which is available to you now. By way of introduction, these are some assumptions, but they are borne out in literature. So there are references to these within the publication. So electronic records do not appear to be realising their full potential for improvements to quality and safety. EHRs appear unable to reflect and support the needs of practice. Poor usability appears to result in workarounds and has been associated with discontent among nurses and adverse patient outcomes. Again, this is all cited in the paper. The COVID pandemic definitely precipitated the adoption of new technologies, but it also shone a spotlight on old technologies. And in terms of some of the deficiencies that are there, made it more apparent in a new context where the electronic records were even more vital than they currently are. And so this led to the kind of assumption that there's a need to reconceptualize the nursing record. So very briefly, in terms of how we did it, we established 3 focus groups. We held them online with a diverse group of stakeholders, the widest group that we could gather together: vendors, informatics specialists, nurse users, managers and leaders. And we had already done a literature review, a systematized literature review previously, which revealed thematic areas. One was standards, one was decision making, one was documenting, and the other one was abstracting, or aggregating, if you like. And we decided to roll abstracting into all of the focus groups, across all focus groups, and each of the focus groups took one of those key areas. We used semi-structured interviews, the same guide for all of the focus groups. They were held in the UK and in the United States. This wasn't a geographical comparison, it was just gathering as wide a range of views as we could. And then the partners themselves, the project partners, analysed their own videos essentially, and they analysed direct from video. They didn't do any transcribing. They used the interview guide to develop a priori codes and to frame the analysis, and they coded independently of the other group, so each group was coded independently. And then the results were synthesized into themes. So the findings are kind of different, even though they had the same kind of framework, different kind of flavour to them. But basically, I won't read through this, actually, it appears in the publication, but you can see the first group had structure, process, purpose, content. Second group had data, not date, capture, and system interoperability. So the importance of standards. So a slightly different flavour here. For documenting, there were 2 areas: barriers and solutions. And then the findings were categorised into those 2 broad categories. So it was a challenge to synthesize such disparate findings, even though we used the same kind of coding framework to do it. So there were total of 47 potential requirements of systems that informed the development of the essentially nursing record system specification. And what it resulted in was 13 development principles, we called them as a group. So I'll skip over this. This is the higher level thematic areas for the development areas. But taking each in turn, for development conditions, these were stated as how things are, not a future state. It's a kind of more like a value, if you like. So there's a shared understanding of purpose. People are prepared for implementation and use. And I think, to some extent, it's stating the obvious. But it is stating the obvious, and it's important to state the obvious because often the obvious gets overlooked. And so some of these will resonate with you. You'll know what I'm talking about. You'll say, well, yes, of course. But then if you reflect a little, do they all apply? Are they all put in place when you're developing systems, when systems are being introduced to you? The second area is interesting. We had an interesting discussion about AI. Can an AI system, can generative AI have values? Can you have a values-based AI system? So thinking, extending the Turing test, I guess. So we called it values because these appear like values that you might have around a system. They're like personal values. So the system is structured around the citizen and coverage of the domain, of course. So that's what I mean by it's kind of obvious, but so often these things aren't covered within development. Next on the system features, things that couldn't easily be categorized apart from, they were just parts of the system. So the system can be customized to individual care. And system functions, systems able to exchange and make use of data from other systems. And standards underpinned by data, documentation, and digital practice standards. So the kind of discussion that comes from this, the kind of thinking about interpreting the findings, that we believed, after doing this work, before and after we did this work, that the frameworks underpinning electronic record systems for nursing are suboptimal. And the people reporting into the study most certainly held that opinion. So that was a wide range of people. There was definitely a call across the board, across the focus groups, for a new inclusive approach to redevelopment, supporting care planning and the patient journey, and packaged in a way that supports procurement and development. And then there was a felt need for culture change that ensures buy-in from all stakeholders. So a culture change around development. Now, I don't know, my experience is limited, but from the implementations I've seen, they're kind of delivered. And the places that they're delivered to goes through a process of culture change, preparation. A lot of it is kind of press key F2 for this, and it's a lot of it is kind of functional. I'm not sure whether you can fully prepare for the culture change that comes from such a technological upheaval. I won't go through these. These appear in the paper, but there was a call from the group of people to refine digital workflow, to support multiple disciplinary pathways, for example, and so it goes on. And this reflects, these are kind of providing at least pointers in a direction that will overcome some of the problems that I heard just this morning about fit with workflow, for example. And then the last point is really important. So there was a realization, but an expectation that people will be required to work differently. And really important that practice would be continually reimagined to support ongoing innovation within the system. So going hand in hand, that practice would change and innovate as the system changes and innovates, both feeding each other. So I think that one thing that was really heartening was that in terms of process, we got a disparate group of people together, and they could come up with a set of requirements. And those requirements could be framed as development principles, at least, if not specific requirements. So speaking about, many talks have talked about the need to include nurses more centrally in the development process. And I think this study shows that it is possible to do that, and so it should happen, because it's possible to do it and to come up with some sensible results at the end of it. Again, the final point is really interesting. People will need to work differently. They're not going to be working the same, of course not. It's a change, it's a complete change, almost a paradigm change, as part of a reimagining of practice. So practice should change because the technology will allow it to change for the better. This is a quote taken from the film Network, which is about a newsreader who realizes that perhaps his life has taken a wrong turn and he'd like to kind of change the world. And I don't know if you know the film, but the final quote is, I'm as mad as hell and I'm not going to take this anymore. And he says, everybody, get up. He's a newsreader. Get up out of your chairs, open the window and shout out loudly, I'm mad as hell and I'm not going to take this anymore. And it's about, kind of economic depression, etc., is the kind of state of the nation. But actually, I'm really quite angry about systems. I think there are exceptions, but I'm kind of angry about the complacency of system development. I've been looking at them. I've been looking at systems for 30 years. When vendors used to let me look at their systems at conferences, it was very interesting that they're kind of vacuous, not much content in there, kind of really nothing that resonates with nursing practice. So I say there are exceptions. I'm not painting everybody like that. But I think the pace of development has been very slow compared to other technologies. I think I've got an example of a slide that I use of different technology, but looking at essentially an electronic recording from 1967, and the form that they use is very much like the interface you would see on a modern day nursing system. So I think the thing that I really want to say is, it's time for nurses to demand the tools that they need to do their job. And it really is. The problem is, what are you asking for? And that's the real problem, is what are you asking for? don't know, but it needs to be better. You know, it's a very difficult situation. So I'd like to frame this differently as a wicked problem. I recognise I have less than 1 minute, but I do need to say, so a wicked problem is a problem that's not understood until after the formulation of a solution. So we won't know what the problem is until we've solved it. And that's a really interesting way of looking at it. The problem's never actually solved, just keeps going. And there is no right or wrong, just better or worse. Every wicked problem is unique. There's no possibility of trial and error. It's a one-shot operation, and then wicked problems have no alternative solutions. So the one approach to solving wicked problems is collaboration. Absolutely collaboration, as wide as you possibly can. Get as many views as you possibly can, and engage all stakeholders, engage meaningfully all stakeholders in the process, so that you can find the best, is there a better solution for everybody, and keep doing that, and keep doing it, and keep doing it, until actually you realise what the problem was you were trying to solve in the first place, which may really disrupt practice. Thank you for indulging me.
So we have 5 minutes. Anybody have a question for Dr. Hardaker?
Thank you for your presentation. Nasser from Saudi Arabia. I just want to ask about, I'm quite concerned about nursing informatics withdrawing more nurses from bedside care. So that is going to exacerbate the nursing shortage. And of course also embedding nursing informatics within pre-registration would produce more of the too-push to wash nurses.
I mean, these are very large questions. I think, you know, there is a balance to be struck between the involvement of nurses in the development of their own systems and whether that's distracting them from practice. I'm not sure of what the drain is towards informatics away from clinical nursing. My experience in this country is not a great deal. You know, I think if we do believe that nursing informatics is a specialty, then we would expect nurses to follow that specialty. And in fact, there is credentialing in different jurisdictions that say, yes, you're a nurse and you specialise in nursing informatics. So it does, you know, I think there always has to be a balance of work and how we distribute that work. But I'm not really seeing a huge weight of informatics nurses. There is a shortage of nurses worldwide. There's a shortage of informatics expertise worldwide. So I think they kind of, that's the balance that we have to decide as a profession, I guess. And then too posh to wash, I don't like that expression. I think I don't know of any nurses that have undergone any training that are not afraid to get stuck in to direct hands-on clinical care. And I'm still a registered nurse. I'm a bit dangerous in my practice now, but if somebody fell on the floor now, I would have no qualms about going on and getting my suit and tie dirty. You know, so I just don't adhere to too posh to wash. I don't think there's anything as too clever. You're too clever to be a nurse, or you believe you're better than you are. You know, I believe nurses are absolutely superb. I'm a nurse. I think as a nurse, I'm absolutely superb. I wish I knew more. Never mind too posh. I wish I knew more. I always wish I knew more. So I'm sorry. I'm kind of saying, no, I don't agree with you, but I'm doing it kind of respectfully.
I do want to expand on that because I am a bedside nurse who transitioned to a clinical informatics role, and it was very challenging for me to have to leave the bedside. I even worked PRN for a certain amount of time because I didn't want to lose all my clinical skills, and I think I'm a better informaticist because I know how to build for the user because I am also a user. Yeah. So I'd push back and say it's not that nurses are leaving, it's that our leadership has not found a model for us to both do bedside care and work on the informatics side or the IT side. Our physician informaticists have figured it out, and so it's so frustrating that they could do a week of clinical and then come back and work on things, and again, they're building for their users, so it's very effective. And the farther I get from the bedside, I'm so worried I'll be less effective at my job. But how do we manage that? How do we fix that pay scale? How do we figure that out? So I would encourage all leaders in here to figure out how you can get nurses to do both, because I think they want to. We want to do both.
Yeah, can I just respond to that? I think we do it to ourselves as a profession. We do. We maintain the gulf. You know, traditionally it was a practice theory gulf, and we had academics and clinical nurses. But we're doing it. No one is making us be like that. You know, and I think it's the same thing. You know, I don't want to get angry. It's not an emotion that I think is a very constructive emotion. But really, you know, we should be really challenging these things.
We need to build for ourselves.
Yeah.
And still be able to participate in the care so we do a good job.
Absolutely, should you choose to. You know, it makes no sense not to deploy people according to their skills and abilities. It makes no sense whatsoever. Thank you.
Thank you, Nick. It's my pleasure to invite to present Miss Chin Wei Lu, who's going to give a presentation on nursing informatics research, a bibliometric analysis from 1989 to 2023.
Good afternoon, everyone. My name is Junwei Liu, and he is Duyan Duan. I'm very happy to talk to you about nursing informatics research, a study from 1989 to 2023. Let's start with a story. A long time ago, a lady named Florence Nightingale helps make hospital better. She used pictures to show how people were getting sick and better. This helped doctors and nurses take better to care of people. Her work was the beginning of what we now call nursing informatics, which helps nurses do their job better with information. Building on what Florence Nightingale started, scientists now use something called bibliometric analysis to see how important studies are. For example, Lu looked at 455 studies from 2009 to 2018, but they didn't check how research topics change. Coco looked at 332 studies from 1987 to 2013, but they didn't check how often these studies were mentioned. Our new study looked at many studies from 1989 to 2023 to see how research topics have changed over time. Now, let's talk about how we did our study. We got our information from a big collection of science articles called the Web of Science. We looked for nursing informatics on December 1st, 2023, and found 652 articles. We only kept the articles that were in English and about the original research, so we end up with 483 articles. To study these articles, we use special tools called bibliometric. We look at 483 articles. We found that every year, more and more people are writing about nursing informatics. This shows that people are getting more interested in learning how to use information to help nurses and patients. Each year, the number of articles grows by about 10.6%. This means more people are studying and doing research in the field, which is good because it helps nurses take better care of people. We also found all these articles come from 34 different countries, almost half of them, 49%. 49% are from the USA. Here is a picture showing the top 10 countries that write about nursing informatics the most. The two colors in the picture show if the articles are made by people from one country or many countries working together. We see that it's not very common for articles to be made by many countries working together. We also look at which journal published these articles. We found out that the articles were in 93 different journals. Most of them, about 60%, were in the top 10 journals. The journal with the most articles was called Computer Informatics Nursing, with 122 with articles. Another important journal was the International Journal of Medical Informatics, which had 42 articles. This shows us which journal people like to read and write in the most when it comes to nursing informatics. We also look at which schools and universities wrote these articles. The article came from 492 different schools, with 80% of them coming from the top 10 schools. Columbia University had the most, with 81 articles. Next were the University of Sao Paulo and the University of Toronto, with 52 and 51 articles. We also look at who wrote this article. There were 1,555 different authors. The top 10 authors wrote 25% of the articles. The authors who wrote the most are Dr. Prose with 23 articles, Dr. Perez with 18 articles, and Dr. Topos with 16 articles. The most famous articles are recommendations of the International Medication Information Association on education in biomedical and healthy informatics, with 188 machines and a Delphi study to determine informatic competencies for nurses at 4 levels of practice with 164 mentions. This picture shows a word cloud of the most common words used in the articles. The biggest words are care and nurses. Other important words are technology, education, and documentation. These words show what the articles talk about the most. We also look at how the main ideas in the article change over time. From 1989 to 2011, people focused on using computer and technology in nursing. From 2012 to 2015, the main ideas were about making sure the technology was easy to use and keep patients safe. From 2016 to 2020, people start talking about big data and helping people understand health information. Recently, from 2021 to 2023, the big topics are AI, understanding language, digital health record, and leadership. Looking at the time from 2021 to 2023, we found some important names in the articles. The basic them are about nursing informatics and medical informatics, focus on leadership and the effects of COVID-19. Important them also include electronic health record and nursing education. Other them are about emotion hospital nursing staff and information communication technology. New and growing them include neutral language processing, clinical detection, and the Omaha system. In conclusion, our study of nursing informatics research from 1989 to 2023. From some important things, we look at 483 articles and found that the USA write the most about this topic. The journal Computer Informatics Nursing has a most article, and Columbia University wrote the most articles with 81. From 2016 to 2020, new ideas like big data, the Omaha system, and healthy literacy become popular. More recently, from 2021 to 2023, important ideas are AI, nursing words that everyone understands, and leadership. Looking ahead, this. The field of nursing informatics is growing fast. It is nursing new ideas like big data and AI. Generative AI will help doctors make better decisions, like better care of patients, and give personalized training. Studies like ours are important of seeing new trends and change in this exciting field. We are excited to see how nursing informatics will continue to improve healthy care for everyone. Thank you for your time.
Thank you very much. We have time for a couple of questions. Why do you sit at the back all the time, Fran?
Thank you. Just from your perspective, what's your thought on how much research there is in nursing informatics? Do you believe there to be enough, or do you think we should be doing more?
你觉得就是现在有多少就是对 nursing informatics 有没有很多的就是了解了，但是其实还没有。She believes that there isn't a lot of understanding within the field of like nursing informatics enough. Sorry, does that answer your question?
Yeah, no. So how do you think we should change that?
你觉得我们要怎么改变它？ She believes that we should actually go through, since the internet is so developed, we should use education and other aspects to work on this, and that will be her suggestion.
Time for one more?
Thank you for your nice presentation. I was just wondering, why did you use Web of Science as a database, not, for instance, like PubMed?
Yeah. She believes that there is a more comprehensive and like a full number of like articles in order to make this analysis. And also it's more like what the field is like wider in some sense.
Hello, thank you so much for your presentation. I would like to ask you if you notice the evolution of the definition of nursing informatics from the 1989 to today, because the definition changed, and if you notice something about this issue. Thank you.
意思就是说，有没有意识到，就是它可能定义 nursing informatics 的定义可能会有点改变。Sorry, can you restate your question or rephrase it?
Did the definition of nursing informatics change through the time period that you?
你觉得就是在那段时间里面 nursing informatics 的定义有没有被改变，还是其实它在1989到现在都还算是蛮一致的？ Okay. She believes that there's like it's pretty consistent throughout like 1989 to now, but there is like a little tweaks or improvements since our technology is improving, and also we as humans are also evolving.
Great, thank you very much.
So it's my pleasure to get to introduce Dr. Sarah Rossetti. She's from Columbia University, the top one of the publishers on the chart that we just saw. She'll be talking about dissemination of strategies for reducing excessive documentation burden, 25x5 task force activities relevant to nursing.
Great, thank you very much. And sorry, here we go. Am I using this? Yes. Wonderful. Great. And yes, I am from Columbia University. I am actually presenting today, really representing work from AMIA, the American Medical Informatics Association, and the 25x5 task force that has been underway for a couple of years this is an effort in the United States to reduce documentation burden to 25% of its current level within the next 5 years. And we have a couple years left in this effort. And I do want to make sure it's clear that the 25x5 task force is focused on reducing documentation burden for all health professionals in the US, licensed, unlicensed, all those performing patient care work. Today, I'll be talking about some particular aspects of that task force as they relate to nursing, which certainly is one of the largest health professions that are experiencing documentation burden. And so the co-authors that you see up here are a subset of our task force, and these are the ones that really were doing some very active work on the components that I'll be speaking about today that relate to nursing documentation burden. I'm starting off with this slide, which I'll get to the methods later. We just completed a survey in the spring on health professionals' burden, but I wanted to start off with this to say, we did this spring confirm data that we've been well aware of in pockets throughout the US and different health systems, different sites, that clinicians really are experiencing documentation burden. And what you see up here, this is a sub-analysis of that survey that we did for the registered nurses that participated. You see the United States there in orange, kind of a dark orange, indicating that they strongly disagree with the statement that the amount of time and effort I spend documenting care is appropriate. They feel that it is not appropriate, the amount of time and effort that they feel that they need to document. And again, confirming the effort that's been going on in the US over the past several years to reduce documentation burden, but also, being here for the past several days, I've been hearing several talks around the issues of nursing documentation burden throughout the world. And I've been both pleased to hear those, as well as, it's, I think, I fully agree with Nick here that you know, it does anger me that our systems are having nurses experience this level of frustration. But very happy that that there is attention, you know, certainly within this conference on this problem as well. And so AMIA's 25 by 5 task force, our mission is a U.S. healthcare workforce free of documentation burden and focused on patient care and improved outcomes. Our vision is reduce U.S. health professionals' documentation burden to 25% of its current state within 5 years, optimize and spread across health systems impactful solutions that decrease non-value added documentation, and leverage partnerships and advocacy with health systems, professional societies, and public-private sector organizations. We're organized into 4 work streams: impact, health professionals, health systems, policy advocacy, and technology requirements. And we have these principles of engagement, and I'll really just point out one really, really core important one, which is that there should be no shifting of burden from one individual or professional role to another. And so we feel very strongly about that in our task force. The task force actually originated with funding for a conference from the National Library of Medicine in the US, and that conference was held in early 2021. And it had over 300 participants. It was on Zoom because of, you know, the period of time in which it took place. And it really identified the need to focus on this area. And after that conference, we identified over 80 action items to kind of move this agenda forward. And AMIA, the American Medical Informatics Association, stepped up to support then that to continue that work. And so they have put forward staff resource time for us, and we have now over 80 individuals who are members of the task force in doing this work. So I'm the chair of the task force, and you see here the names of some of the key leaders within the task force. Ken Riccido, who's here at the conference, is our board liaison. And we have John Windle, we have Sarah Corley, Vicky Tiazzi, and Elise Rouen, who lead these different work streams. And then this is a list of members of our task force. And so these are AMIA members who then are members of our 4 different work streams in conducting this work. I wanted to highlight, before I jump into the use cases that relate to nursing burden that I'll highlight, because there is other work going on within the 25 by 5 task force, I wanted to highlight one of the key frameworks that we use as a task force. And it's a framework from ANIA, the American Nursing Informatics Association. And it really has successfully informed our work for burden for all health professionals. You know, they really captured it well here in these 6 domains of burden. And this is a US-centric viewpoint of it. You see reimbursement is one of the top ones up there. That certainly is a big player in the United States. Also regulatory requirements. I think I was in a session yesterday where there was a discussion that, and it was for some work around burden in Canada, the regulatory requirements are very different and they're able to make different decisions there. In the US, regulatory requirements are something that our hospitals and our health systems really struggle with, trying to move beyond those or how to handle them effectively within our records. Quality measures, that refers to usability. Usability is the theme that we have found in our work is cross-cutting across all of these themes. We have a publication coming out very soon on the definition of documentation burden in a scoping review, looking at an extensive body of work that's discussed the issue of documentation burden, and usability is the consistent theme in all of these aspects of burden. Interoperability, also a key theme there. And this theme of self-imposed, or this category of self-imposed. The way we see this has played out in the United States is that a hospital may overbuild their EHR record. And this is perhaps or often in response to regulatory requirements, but they're going beyond what the regulations actually say, and there can be some miscommunication there in what's really required, but it's kind of this legal compliance perspective to make sure we have everything covered. And this really impacts our nurses. And so this is a list of our current activities from the task force, as well as some of the resources that we've published and made available. You can all go to AMIA's 25x5 website to find any of them. And I'm just highlighting here the ones that I'll speak about briefly today. I also want to mention that we've put together a logic model that brings together all the work that we're doing, because as a task force, we've said we're reducing documentation burden to 25% of its current state. And so that logic model is our approach to how we'll be able to demonstrate that reduction, kind of from triangulating the work that we've done with some quantitative as well as qualitative findings in there. So first, I'm going to talk about our toolkit for reducing documentation burden. And this has been posted on AMIA's website for a bit over a year now. And so it was developed based on a scoping review, and Liz Sloss, who's actually here at the conference here, really led a lot of this work. Looking at the range of documentation burden reduction efforts that have happened, and the methods and tools for that. And with some expert consensus on our task force, as well as some surveys of health systems and some iterative revisions, posted this online just a year ago, or in spring of 2023. And the target is healthcare delivery organizations, so hospitals and health systems who want to start somewhere with reducing burden in their records, but maybe don't know exactly where to start. So we found that there are some, particularly in the US, some academic medical centers who have done a great job in reducing burden, reducing clicks for nurses, and made some real strides in that area, but the knowledge wasn't being shared throughout our country, really, to perhaps some more community hospitals or places that didn't have nursing informatics research. And so this is posted on AMIA's website there. And you can see that QR code. And I think here, yep, so it's had greater than 2,000 unique views and over 1,800 downloads. We also then, kind of associated with this, have a Slack channel of 185 members representing health systems and other healthcare delivery organizations. We held a webinar in March with over 200 registrants talking about some of the components in here, and are doing some surveys of it as well now. So the second one that I'll talk about is our trend burden survey. And so we developed this because there isn't really a survey for all health professionals and burden, to measure their burden across all types of health professionals. And we wanted it to be brief, what we call a pulse survey. So we can send this out every 6 months. It's only 5 questions so that we can trend the pulse of our nation on how we're doing on burden. And we developed this with a scoping review, and then we had a Delphi process within our task force to bring down the number of items to 5 questions. And so these are the questions here. The amount of time and effort I spent documenting patient care is appropriate. I finish work later than desired or needed, or need to, due to work at home because of excessive documentation tasks. Recently, there's been a noticeable decrease in the time or effort, or both, needed for me to complete my documentation. The effort or time required for me to complete documentation tasks impedes patient care, and I find it easy to document patient care using the electronic health record. And so we sent this out in April. We'll send it out again in a couple of months, and then every 6 months after that. We had 1,200 responses from across the country. 25% of the responses were from registered nurses. And where AMIA is making this data openly available. So you can download the results, the actual data sets, because we want people to be able to analyze this. We want to join forces to get much of the country responding to this survey. I'm going to skip ahead just for time in terms of who's responding, but it's from a variety of inpatient and outpatient settings and types of clinics, for example, as well. We're really going to be making efforts to increase the generalizability of it. What I've highlighted here is this is just showing across the different types of professionals that answered, you know, in terms of the big buckets, physician, RN, and then advanced practice, nurses and PAs, they're pretty consistently answering in the same way. And their answers across those 5 questions all align with, yes, they're agreeing and strongly agreeing that burden is excessive. These are the specific nurse results here, and you see they disagree that the time and effort is appropriate. They finish work, they agree that they're finishing work later. There has not been a noticeable decrease in time or effort, and the effort or time impedes patient care, and they do not find it easy to document in the record. And so the third project that I'll highlight is our HIT roadmap to promote interoperability. And so this was from our technology requirements work stream. And they really took some stuff from our original symposium and tried to come up with a map for the next over kind of 3 years. And this is from an industry technology perspective. And just to highlight what here is relevant to nursing is in this less than 18-month box over here is movement towards ambient technology for better data capture. And I really see that as one of the ones that is highly relevant to nursing. And then we see some in the middle box there talking about better synthesis and summarization of the record. And then here just better kind of navigation within the record, and I think really strongly better tools for usability as well. But that's how I see this roadmap, which is relevant for all health professionals, relates to what we're learning, really is what nursing needs. And I'm going to wrap up here with this quote. Much like how the national movement to improve the safety and quality of care delivery has gained ground over the last 20 years, improving health worker well-being will be a long journey. So in the United States, the National Academy of Medicine has recognized that documentation burden and health professional well-being is in dire need. Our Office of Surgeon General, a key leader within our healthcare system, has been a huge vocal proponent in the past year and a half for this as well. And I really think this resonates, us as informaticians, we know the huge patient safety focus that occurred, 20 plus years ago. And this is really, I think, a very needed and big movement now to recognize, I think, the extent of interventions needed for healthcare worker well-being, and we see documentation burden as a very big part of that. Thank you.
Is this working yet? There we go. It takes a minute to warm up. 5 minutes for questions, but my one comment, I'm real happy to see standards on there, but I'm sad that it's a long-term, way up there in the future. Because we've been working on it for years and years. Any questions?
Hello. I don't disagree at all that nurses feel that there's a great documentation burden. I absolutely get that, and I have the same conversation with nurses in my hospital environment. I think what I'm wondering is to what extent we've correlated that with actual observations of how much time they spend documenting, because I think nurses come into nursing because they want to be hands-on with patients, delivering care, and I sometimes wonder if they don't see the professional value in undertaking the risk assessments, making the nursing diagnosis, handing over care. And I think if we were able to better demonstrate that professional value of our documentation, it wouldn't feel so much like a burden when we do need to spend time doing it. I'm sort of long enough in the tooth to remember the time when nurses used to complain about the amount of paperwork that they did.
Yeah.
in the same way that they now complain about the computer work that they have to do. And I do wonder sometimes if it's because they just don't want to do it.
You know, I think my answer is going to be pretty US-centric, and I'm saying that kind of in a confident way, having been at a few sessions over the past day as well, plus based on my own research findings. In my research, I've actually done studies looking at this notion of kind of optional documentation versus all the required documentation. In the US, there is a large amount of required documentation by nurses. And even if the regulatory groups aren't requiring it specifically, the hospitals are. And our EHRs actually have the decision support largely for nurses in our EHRs is saying that they have not yet completed particular documentation tasks. So the burden is not just the structured fields they need to fill out, but it's our reminders to them to go fill out those structured fields. And time-based studies too that have looked at the amount of documentation does support that it's excessive, you know, a reasonable person kind of thinking that that's excessive. What's very interesting is during the COVID pandemic, at least in New York State, the governor said you don't need to document except for medications. This was all health professionals. You will not be held liable if you don't record something. And so we have a study right now funded by AHRQ, which is the Agency for Healthcare Research and Quality, where we're looking at this in the sense of a natural experiment. We can see what nurses chose to document when they no longer had to document anything except medications they gave to the patients. And what we see is they're still documenting. So I lead with Ken Orcato what's called the Concern Study, where we actually use nursing documentation patterns to predict patient deterioration. We've still been able to predict that patient deterioration. They go in the room, they survey the patients, they're still putting that critical information into the system, but they didn't have to do all this other stuff. And so I believe, based on the data that we have, that our nurses are, you know, professional nurses, and they are performing their professional practice, and they record it so that other care team members see this information. They see, you know, the importance of it, but there is so much other information in that system that takes up so much of their time and is burdensome. And that's the hope, that we can identify and classify what that is and get rid of it.
Thank you, Dr. Rossetti. We're out of time, but she'll be around. I know a lot of you would like to talk to her, so thank you so much.
Thanks.
Thank you. So I'd now like to invite to the stage Melanie Robertson and Stephen Down, who are going to do a presentation on using technology to improve the mental capacity assessment and deprivation of liberty safeguards process.
Thank you. My name's Melanie Robertson. I'm the Chief Nurse Informatics Officer at South Tyneside and Sunderland NHS Foundation Trust, and this is Stephen Downs, who's our mental capacity lead. I'll pass you over to Stephen to introduce the topic.
Okay, so first of all, can you hear me okay? Good. What is the Mental Capacity Act and what are the deprivation of liberty safeguards? Can you hear me better now? Okay, thank you. Mental Capacity Act effectively is an English law, English and Welsh law, around putting a structure around the consent process. So the idea is that it promotes the rights of everyone over 16 to decide what happens to their own body, to make their own care and treatment, finance and property decisions. There's a legal process on how we assess mental capacity, and there's also some kind of structure around how we therefore make decisions for people who lack capacity to make their own health and care and treatment decisions. And there are mechanisms that allow us to plan for the future, for a point in time when maybe we lose capacity to make decisions for ourselves. Deprivation of liberty safeguards, not nearly as gruesome as it sounds. It's not about removing liberty, taking away freedom from people. It's about recognising that there's a cohort of patients who are not able to consent to be in hospital and receive their care and support. So it creates a system of independent scrutiny to make sure any restrictions in their care are necessary, proportionate and in their best interests.
Did you want to go over the CQC issues?
Yep, it hasn't moved on yet. Looking for that to move on.
No, how's that?
That's good.
Yeah, so we went from that one to that one.
That one, right, okay. So, what was our reason for change? So we had an inspection from the Care Quality Commission, who are our regulators and inspectors. And they highlighted several areas of concern in relation to Mental Capacity Act and DOLS applications. So the first one was around assessing at the point of admission, where we were actually capturing at the point somebody came into hospital, whether or not they were able to consent to that. And they felt very much, although we were doing quite a lot of that, we weren't doing enough. In terms of making best interest decisions for people, what they found was very little evidence that we were consulting the person or consulting the family and equally capturing what those people had to say. They found that the views of patients in particular were difficult to gather, but the views of family were being recorded in other places, but not necessarily around the decision making itself. They also want to ensure we capture the views of delegated decision makers. So as I said a little earlier, there are mechanisms to plan ahead for the future, things called lasting powers of attorney, deputyship, etc. So were we actually following the law and making sure we were identifying who those people were, what authority they had, and what their opinions were. In terms of DOLS, we need to make sure we had the legal authority to deprive patients of their liberty. The test for that is very low. So the test became commonly known as the acid test, is can the person consent to be in the hospital? Are they under 24-hour supervision and care from our staff? And would we let that patient just leave and walk? The process is we can grant ourselves permission initially once we recognise somebody might be deprived of the liberty to allow the process for local authority to come along and assess the patient's restrictions and hopefully authorise their deprivation for as long as necessary for the patient to be there. We need to have robust systems in place to make sure that we were monitoring, that we were capturing everyone who should be receiving a DOLS application. So basically the challenge for us was, could we evidence we were assessing capacity when we needed to assess it? Could we evidence we were involved in the views of the patient, their families and delegate decision makers? Were we then following it up when someone couldn't consent with the DOLS process to make sure there's independent scrutiny of those care measures?
So given that we thought that we were doing this well and CQC felt that actually we had areas to improve, we formed a project group. We're a digitally mature organisation. We don't really have much in the way of paperwork in our ward and department areas anymore. So the project group felt it was really important that we established this within our electronic health record. So the group was formed, led by myself and members of the safeguarding team, with representation from IT, but also from the clinical areas. We wanted to do this multi-professionally and involved medics, therapists and nurses with the process. We reviewed our current documentation and we considered how we wanted to make some changes to the record and how we would implement those, and we launched and implemented that. We formed links with the local authority to think about the formatting and the wording of some of that documentation, and we developed some tools to help us monitor our compliance and then did some further refinement work. So one of the particular issues that we identified, and I'll just talk you through a number of the issues and how we went about trying to improve things, is we had a lack of organisational awareness in terms of how many patients lacked capacity in our organisation, and whether actually, we had no sort of numerator to determine our performance against it. And that's partly down to the legislation being around assumptions that you would naturally make, that you should assume that somebody has capacity unless you've got reason to doubt that. We decided to add in this specific question so that people were actually acknowledging that they'd made that assumption, and that allowed us to then almost determined the number of patients that needed that full mental capacity completing. And we actually had no way in the system of prompting and reminding clinical staff that they needed to do this. So adding in this prompt around, following that question, if somebody identified that the patient might lack capacity, prompted them to go ahead and do that full assessment. When we looked at the mental capacity assessments themselves, we just felt that they really weren't user-friendly at all. They were a standalone assessment within the electronic record that somebody would need to go and seek out, very separate to that regular process, where now as doctors and nurses assess the patient and take that initial clinical history, we simply ask them to add a section into the documentation if they ask that reasonable doubt question and feel that there could be some concern. We felt that the wording was very complicated. There was a lot of double negatives in it that really just didn't make a lot of sense and confused people. And I think when people don't understand something, they don't engage with it very well. So there was an exercise to try to streamline and improve that wording. And also the requirement to undertake a DOLS if the patient was assessed as lacking capacity wasn't actionable. So in some cases, the medics would fill the DOLS application, and in some cases it would be the nurses, but there was no way of one professional telling the other professional, it's yours to do, or this needs to be done. It was just sort of left in the ether there somewhere, so we needed to make that more actionable. And then part of the refinement work around this, that reasonable doubt question, we asked that at the very start of that initial assessment because we felt as soon as you approach the patient, you would want to make a decision, you know, do I doubt what's, you know, that this patient has capacity. But what we actually found is that everybody makes that judgment that this patient appears to have capacity. And by the end of that assessment, sometimes they then felt, hang on a minute, I need to do a mental capacity assessment because they've built that relationship up and they've established that actually that there is something here that I'm a little bit unsure about. So we moved that question to the end of the documentation, and we suddenly saw a big uptake in the amount of capacity assessments that were filling in, and that just shows you a little screenshot of the add section. You'll see along the top we've got the history, general exam, all the different sections that the initial clinician will work through, and the added section for MCA 1 and 2, and the outcome there, which is actionable, whether the nurse or the medic is actually going to proceed to complete the DOLS. Particularly from a nursing point of view, we felt that our documentation didn't actually reflect that awareness of whether a patient did or didn't have capacity. And in not having that awareness really obvious, there wasn't a way that we could actually describe what reasonable adjustments we'd made. If somebody lacks capacity and they decline and refuse in care, you know, how have we worked with that patient? How have we worked with their family? How have we adapted things and our approach so that we're actually able to provide that standard of care? So we created a separate evaluation which the nurse would pick up from their work list. And you'll see along the top, this is the evaluation particularly for patients that lack capacity. It tells us at the start that the doctor's going to complete the DOLS, so we can see that action there. And you'll see on the example here around eating and drinking, if the nurse has indicated that no, that standard hasn't been met, there is a further prompt that reminds the nurse, actually, that's not reasonable, you do need to proceed and try to investigate that further to provide that level of care. We then felt that we needed some data, and we did some work so that we could manage this activity and look at our performance and see areas where we could improve it. The safeguarding team themselves worked with our information support services to provide a launchpad report so they could run that and see how many patients had mental capacity assessments filled in, who had a reasonable doubt question and who'd had DOLS filled in. And that was great, that's really helpful. But actually, what we needed was the staff to have their own clinical engagement of that information. So we developed this question on the status board, which is a status board that the ward managers use to monitor that things are done in a timely fashion, and you'll see it's fairly straightforward as to whether something's needed, with an obvious gap if something isn't completed, and that just gave the wards themselves that own operational ownership. I'll go back over to Stephen here to talk briefly about what improvements we actually saw.
Just to note as well, some of the improvements we made, like moving the question, were through consultant staff who filled in those assessments every day to see what works better for you. What we found before the CQC inspection, we were getting round about 140 DOLS applications a month, which sounds reasonable. What we found after the improvement work, that figure averaged round about 400 a month. So it made a significant improvement. And everyone who's had a DOLS application therefore had at least one mental capacity assessment. We also included a similar question in the first consultant ward round, just to check whether initial facts, initial presentation was the same or had changed. So what we did then is work with our local authority partners around the accuracy of some of those DOLS referrals, because the way the law is structured, we have to apply for DOLS as soon as we feel the patient lacks capacity consent, but our average admission was for around 6 days. The law allows us to self-authorise for 7. So we had to do some work with the local authorities around improving the quality of some of those referrals and the accuracy of some of those referrals. But having the Launchpad system in place gave us the tools to have more accurate data to do that with. So, what are the benefits of it? Well, firstly, it means the rights of patients are protected. It means we're recording their views and wishes and feelings. It means that in terms of staff, we've created a more streamlined structure to make sure they can comply with the law and evidence their practice for others following on. In terms of our organisation, we're in a better position in terms of our assurance. We can now pinpoint more accurately the data in terms of the numbers we're creating, the quality we're creating. We've made some changes that we can evidence have improved our practice and compliance. And in terms of the local authority, we're now giving them data in much more of a real-time situation. And we've increased the referrals, but as I said before, improved the quality of those referrals at the same time. Very, very recent data as of yesterday is what we're finding is actually the quality is starting to improve as well by simple things like replacing comments with what did the patient say, what did the family say. Simple language has improved the quality significantly.
Thank you. Any questions?
Any questions? I have one. While you were redesigning the systems and the forms, did you also do additional MCA DOLS training for the staff?
Yeah.
Yeah, as well as sort of statutory and mandatory training, which is largely e-learning packages, we do, what I've found is a lot of the training we've made bespoke. So we've tried to focus on, say, renal care, for example. What are the kind of common issues that arise in renal care? And we've tried to create training packages around case studies, for example, of the kind of common issues and challenges you might find. And what we found in that way, we've got a lot more engagement, particularly from the medical staff, regarding, you know, the value of MCA, because I think there was a risk, particularly during COVID, when everybody's really busy, of seeing it as a task and not really understanding the value it adds, particularly to the patient.
Great, thank you.
Hi, that was really useful. I was just wondering, what kind of patient group are you looking at? Because mental capacity is fluid and it can change. So, you know, where would be this most suitable to be implemented?
I mean, it's something that we there's an expectation that all patients have this assessment made. I mean, clearly areas like care of the elderly are areas that are probably the best engaged because it's the most clinically relevant, you know. But if a patient were to come in intoxicated with alcohol, you know, it is still clinically relevant at that point in time to think about their capacity, or if they've had a head injury. So it's not something that is confined only to care of the elderly.
To give some statistics, about 45% of our admissions come from care homes. So quite a lot of those are elderly patients or patients maybe with a learning disability, but also lots of delirium, sometimes multiple conditions. So as well as the temporary things like intoxication, which generally resolve fairly quickly, we get a lot of sort of longer term care, a lot of elderly care patients.
Any more questions? Okay, thank you very much.
Thank you, everybody. This concludes this session. If you are going to the dinner tonight, you should have received an email with the instructions. They have got that sent out. If not, let them know. And this has really been enjoyable. Thank you very much.